So today we start skeletal muscle relaxant, or it is also known as neuromuscular blocking agents. Skeletal muscle relaxants are used as an adjuvant with general anesthesia to obtain relaxation of skeletal muscle prior to the surgery. Classification of skeletal muscle relaxants are peripherally acting skeletal muscle relaxant, centrally acting skeletal muscle relaxant, directly acting skeletal muscle relaxant, and miscellaneous agents. These skeletal muscle relaxants are classified according to their mechanism of action as well as their site of action. First group is peripherally acting skeletal muscle relaxants. It is further divided into non-depolarizing skeletal muscle relaxant and depolarizing skeletal muscle relaxant. Non-depolarizing skeletal muscle relaxants are divided into longer acting, intermediate acting, and short acting skeletal muscle relaxants. Longer acting skeletal muscle relaxant includes D-tubocurarium, doxycurarium, pancuranium, and pipecuranium. Intermediate acting includes atracurium, cisatracurium, vacuronium, and rocuronium. Short acting skeletal muscle relaxant includes mivacurium and rapacuronium. Here, this curarine or doxycurium are isoquinoline derivatives, and drugs which contain curonium are steroidal derivatives. Second group is depolarizing skeletal muscle relaxant. It contains only one drug, which is succinylcholine. Next is centrally acting skeletal muscle relaxants. Centrally acting skeletal muscle relaxants are divided into number one mefenacin group, which includes carisoprodol, chlorzoxazone, and methocarbamol. Second group is benzodiazepines, which includes diazepam and clonazepam. Third group is GABA derivatives, which includes baclofen. And fourth group is selective alpha-2 agonist, which includes tizanidine. Next group is directly acting skeletal muscle relaxant. It includes only one drug, which is dantrolene. And fourth group is miscellaneous skeletal muscle relaxant, which includes quinine, gabapentin, botulinum, and ribosome. Now come to peripherally acting skeletal muscle relaxant. First we discuss non-depolarizing skeletal muscle relaxant. Non-depolarizing skeletal muscle relaxant includes prototype drug, D-tubocurarium, and other drugs like atracurium, cisatracurium, and many more. Now come to their mechanism of action. What happened normally? Normally, this acetylcholine binds with these NM receptors, which are present in the motor end plate of the skeletal muscle. This acetylcholine binds with this receptor, which leads to opening of these sodium channels. And influx of sodium ion leads to depolarization, which results into muscle contraction. But what happens if we give non-depolarizing skeletal muscle relaxant like D-tubocurarium? D-tubocurarium has affinity but does not have intrinsic activity, which means it binds with these NM receptors. This D-tubocurarium binds with these NM receptors because it is a bulky molecule. It binds with these NM receptors and prevent the binding of acetylcholine to these receptors. Therefore, necessary conformational change required for opening of sodium channel does not happen. And in absence of depolarization, muscle goes into relaxed state. Now come to some important pharmacokinetic and pharmacodynamic properties of non-depolarizing skeletal muscle relaxants. Number one is these non-depolarizing skeletal muscle relaxants are bulky, polarized quaternary compound. If these drugs are administered orally, they cannot be absorbed. Therefore, these drugs should be administered intravenously. These drugs should be administered intravenously. Number two, these drugs have lower operant volume of distribution. These drugs mainly confined in the extracellular space following intravenous administration. Number three, where these drugs are administered, these drug does not cross blood-brain barrier. Therefore, they does not have any CNS toxicity except atracuria. Because this is a quaternary compound, this drug also does not cross placental barrier. Therefore, this drug can be successfully used during cesarean section. Number 4, some drugs, some isoquinoline derivatives like atracurium and cisatracurium are spontaneously metabolized in the plasma, which is known as Hoffman's elimination. Here, after Hoffman's elimination, breakdown product is formed, which is known as laudanosine. Laudanosine does not have skeletal muscle relaxant property, but this laudanosine can cross blood-brain barrier and can precipitate seizures. Now come to their important pharmacodynamic properties. Number 1, skeletal muscle paralysis or skeletal muscle relaxation. By acting on these NM receptor, these drug produces progressive flaccid paralysis. Fast moving muscles are affected first, like muscles of jaw, face, tongue, neck are affected first. Thereafter, large muscles like muscles of abdomen and limbs get affected, and finally intercostal muscles and diaphragm get paralyzed. Recovery occurs in reverse manner, which means recovery of large muscle occurs first and then recovery of small muscle occurs. Second is histamine release. These drugs, especially isoquinoline derivatives, liberate histamine from mast cell. Number 3 is cardiovascular effect. These drugs, especially isoquinoline derivatives, may precipitate postural hypotension. Mainly because of liberation of histamine, and also these drugs produces some respiratory effect, like these drugs can precipitate bronchoconstriction due to release of histamine from the mast cell. And number 5 is gastrointestinal effect. These drugs decreases the tone and motility of GIT. Therefore, this drug can precipitate constipation. Blocking of these skeletal muscle relaxant or reversal of these skeletal muscle relaxant can be done by administering neostigmine or pyridostigmine. Because the blockage produced by these detuberculin are competitive or surmountable blockage. Therefore, by administering these neostigmine and pyridostigmine, these are anticholesterase drugs, they increases the concentration of acetylcholine, which displaces detuberculin from NM receptor, and again it can produce depolarization and muscle contraction. These non-depolarizing drugs are associated with certain adverse effects, Number one and most important is hypoxia or respiratory paralysis. The treatment of hypoxia or respiratory paralysis can be done by giving artificial respiration or by administering neostimulant. Other adverse effects of these non-depolarizing skeletal muscle relaxants are hypotension, especially postural hypotension, bronchoconstriction and constipation. Now come to another peripherally acting skeletal muscle relaxant, which is depolarizing skeletal muscle relaxant. It includes succinylcholine. Succinylcholine binds with these NM receptors because it is a quaternary compound. It is a heavy molecule, bulky molecule. It binds with these receptors and causes opening of these sodium channels, which lead to depolarization. But this succinylcholine repeatedly stimulates these NM receptors, which lead to repeated stimulation of muscle motor unit. Initially, there is fasciculation of the muscle motor unit, fasciculation of muscle, followed by their desensitization. Due to repeatedly stimulation of these receptors, there is desensitization of muscle motor unit. During depolarization, another acetylcholine is released. This acetylcholine further act on these NM receptors, further stimulate these NM receptors, and repeated stimulation of these receptors leads to their desensitization, which causes skeletal muscle relaxation, which produces skeletal muscle relaxation. These succinylcholine have certain pharmacokinetic and pharmacodynamic properties. First, we discuss important pharmacokinetic properties. This succinylcholine is a quaternary compound. Therefore, if it is administered orally, it cannot be absorbed. Therefore, preferentially it is administered by intravenous route. Number two, this succinylcholine has shorter duration of action because it is rapidly metabolized by pseudocholinesterase enzyme. It is rapidly metabolized by pseudocholinesterase enzyme. Number three, in certain individual, genetic variations are present, genetic variations are seen. In place of pseudocholinesterase enzyme, atypical pseudocholinesterase enzymes are present in these susceptible individuals. This atypical pseudocholinesterase enzyme does not metabolize these succinylcholine sufficiently, which leads to toxicity of succinylcholine, which can precipitate apnea, prolonged apnea. And this ability of pseudocholinesterase enzyme to metabolize succinylcholine is identified by the Bouquet number. Now come to some pharmacodynamic properties. This succinylcholine produces skeletal muscle relaxant, but the sequence of paralysis differs from non-depolarizing skeletal muscle relaxant. Initially, it produces twitches on cheeks and abdomen, followed by relaxation of muscles of neck, limbs, trunks, and then paralysis of respiratory muscles occurs. Due to repeated stimulation of muscle motor unit, initially there is fasciculation, which leads to muscle soreness. And number two is, initially this succinylcholine produces bradycardia, and on high dose or in prolonged treatment, it can precipitate tachycardia. Now come to their adverse effects. Succinylcholine are associated with certain adverse effects. Number one, hyperkalemia due to efflux of potassium ion from the cell. Number two is malignant hyperthermia. Number three is masseter muscle rigidity. These both are autosomal dominant conditions, genetically inherited autosomal dominant conditions. Number four is apnea, and the chances of prolonged apnea are more in presence of atypical pseudocholinesterase enzyme. Next adverse effect is these drugs can increases intraocular pressure. Next is this drug can also increases intragastric pressure, which leads to nausea, vomiting. And another adverse effect with succinylcholine is muscle soreness due to initial fasciculation. Now, what are the difference between D-tuberculin and succinylcholine? D-tuberculin produces competitive blockage of NM receptors, whereas succinylcholine produces persistent depolarization followed by skeletal muscle relaxation. Number 2, D-tuberculin produces progressive flaccid paralysis, whereas succinylcholine produces initial fasciculation followed by skeletal muscle paralysis. Number 3, the reversal of blockage produced by D-tuberculin can be achieved by administration of neostigmine or by sugammadex. But reversal of succinylcholine are not possible by administration of neostigmine. Even there is potentiation of skeletal muscle relaxation are seen if we administer neostigmine with succinylcholine. D-tuberculin, when administered, it stimulates histamine release from the mast cell, but succinylcholine does not stimulate histamine release or only minimally stimulate histamine release. Number 5, D-tuberculin does not produce muscle soreness, whereas succinylcholine produces muscle soreness due to initial fasciculation induced damage to the skeletal muscle. D-tuberculin does not increase intraocular pressure, whereas succinylcholine can increase intraocular pressure. Number 7 is cardiovascular effect. D-tuberculin can produces hypertension, whereas succinylcholine can produces hypotension as well as hypertension. D-tuberculin can precipitate constipation, whereas succinylcholine can precipitate nausea and vomiting after recovery. D-tuberculin produces bronchoconstriction, whereas succinylcholine does not precipitate bronchoconstriction. There is no genetic variation is seen in the D-tuberculin, but there is genetic variation is seen in the succinylcholine metabolism. There is genetic variation is seen in the atypical pseudocholinesterase enzyme, which leads to prolonged apnea. Now come to important uses of peripherally acting skeletal muscle relaxant. Number 1, they are used as adjuvant during surgical anesthesia to obtain relaxation of skeletal muscle, so that operative manipulations, orthopedic manipulation, abdominal surgeries become easier. Number 2, these drugs are also used prior to electroconvulsive therapy to prevent trauma. Number 3, these drugs are also used in certain spastic conditions like tetanus or status epilepticus.